There are 2 states, actually 3 states now in the country that have publicly reported outcomes for PCI related to mortality outcomes, hospital publicly reported outcomes. Those are Massachusetts, New York, and the state of Washington. What we wanted to look at was whether or not those public reported outcomes, that policy influenced actual patient outcomes in patients who presented with myocardial infarction. There's obviously the intent of that policy implemented in New York, Massachusetts, most long-standing in New York and Massachusetts, is that this would improve clinical outcomes because people would focus on quality. As a clinician, I think we know that what it's led to, because it focuses on a procedural outcome, is that there are some patients for whom if some docs may think that, gee, I don't think I'm going to be able to achieve a good outcome here, they may in fact not offer that procedure. And so that could actually lead to a denial of care. So those things, you could imagine that there might be some improvement and some lack of improvement on that basis. And we wanted to study what happened. We used a database called the Nationwide Inpatient Sample, and we compared patients who presented with myocardial infarction in New York and in Massachusetts to those presenting with myocardial infarction in several regional comparator states. What we found, and this has been described previously, and we I think confirmed it in a broader population, patients in Massachusetts and New York are less likely to undergo PCI, undergo stent procedures, than patients in regional comparator states without public reporting. And that effect is strongest in the highest risk patients presenting with shock or cardiac arrest. Those are precisely the patients that one might anticipate would benefit the most from PCI. They are actually receiving PCI the least in the public reporting states. The more important outcome of the study is that when we look globally at all patients who presented with myocardial infarction, they actually have worse risk-adjusted mortality rates in Massachusetts and New York compared to regional comparator states. And so if you look at the PCI patient population, they do better as expected. That's the intended consequence of public reporting, is improvement in PCI outcomes. But look at those patients who did not receive PCI, and they did much worse. And those data all suggest that physicians are practicing risk-averse behavior. They're avoiding the patients who might benefit. The end result is that the total population of MI patients does worse, even though the procedural outcomes maybe look better. I think we need to do a few things. I think we need to understand what are the concerns of physicians. The public reporting that we utilize in Massachusetts and New York is risk-adjusted, and is it that the risk adjustment statistical methods are not trusted by the physicians enough to what they think account for the risk that they're taking on when they do it? That's a possibility. Certainly physicians and policymakers have worked hand in hand in both states, but in particular in Massachusetts, to refine the risk adjustment procedures. We've come a long way since 2003 when they were first implemented. I think we need to continue to refine them to understand what physicians' concerns are with the risk adjustment process. I think the second thing is education among physicians. I think that first do no harm is a great principle, and we all want to abide by that, obviously. But there is also this aspect when there's a secondary issue of as a physician, one's livelihood and coming under scrutiny for things. Sometimes it's easier just to say, nope, I'm not going to do that one. And I think we need to alter the policy in a way that addresses physicians' concerns. There's some barrier between the communication of the policymakers and the physicians, and I think we need to bridge that barrier in order to overcome some of this.